Let's get into one of the most classic Step 2 CK topics, valvular heart diseases. This one is massive, but if you understand the flow of physiology and the murmurs, you'll easily get through every question they can throw at you. We'll start with infective endocarditis and when to give prophylaxis, then talk about benign versus pathologic murmurs, and finally move through the big valve lesions, mitral stenosis, mitral regurgitation, MVP, aortic stenosis, pulmonic and tricuspid disease. Alright, let's start with something that shows up in both medicine and cardiology blocks, infective endocarditis prophylaxis. Only a small group of patients actually need antibiotics before procedures, and Step 2 loves to test who's on that list. The high-risk group includes anyone with a prosthetic heart valve, previous infective endocarditis, a structural valve abnormality in a transplanted heart, unrepaired cyanotic congenital heart disease, or a repaired congenital heart disease with a residual defect. In these patients, bacteria can seed a tiny thrombus that forms on the valve during transient bacteremia. Most of the time, that bacteremia comes from daily activities like brushing teeth, but it increases a lot with invasive procedures. So which procedures are high risk? Think about anything that can break through mucosal surfaces. Dental work that goes into the gums, tonsillectomy, bronchoscopy with biopsy, or surgery on infected skin or soft tissue. GU or GI procedures only matter if there's active infection in that area. For prophylaxis, you give antibiotics 30 to 60 minutes before the procedure. The standard is oral amoxicillin, 2 grams, usually for dental or respiratory procedures. If there's an active GU or GI infection, you also cover enterococcus with the same. For procedures on infected skin or soft tissue, you give 4 vancomycin to cover staph. That's it, very testable. If it's not one of these procedures or one of these high-risk groups, no prophylaxis. Now, let's move on to one of the Step 2 favorites, differentiating benign from pathologic murmurs in kids. This is high yield not just for peds but for internal medicine reasoning too. A benign murmur means the patient has no symptoms, normal growth, and no significant family history. The murmur is early or mid-systolic, musical or vibratory, grade 1 or 2, and it gets softer or disappears with standing or Valsalva. A pathologic murmur, on the other hand, is holosystolic or diastolic, harsh, grade 3 or louder, and it doesn't go away with standing or Valsalva. You'll often see other red flags: poor weight gain, respiratory distress, exertional fatigue, syncope, or family history of sudden cardiac death. Always check the pulses: weak femoral pulses, a loud or single S2, or hepatomegaly means something real is going on. If the murmur is benign, reassure the parents. If it's pathologic, get an echo. And here's a fun note: the venous hum is the exception. It actually gets louder when standing. Now, let's go through the main murmurs you'll hear in valvular disease. Start with mitral stenosis. The classic sound is an opening snap followed by a mid-diastolic rumble best heard at the apex. Mitral stenosis is most common in women, and the big cause worldwide is rheumatic heart disease. It often shows up years after the original infection, and patients come in with exertional dyspnea, orthopnea, and sometimes hemoptysis. As the disease progresses, they can develop right-sided heart failure with leg edema. When you see a patient with new-onset atrial fibrillation in the setting of mitral stenosis, that's dangerous. They lose their atrial kick, can suddenly decompensate into pulmonary edema, and are at high risk for embolic stroke. That's why anticoagulation with warfarin is indicated even if the CHA2DS2-VSC score is low. Definitive treatment is percutaneous valvotomy or valve replacement. Alright, next, mitral regurgitation. The murmur is a classic holosystolic murmur best heard at the apex, and it often radiates to the axilla. Let's start with acute MR. This usually happens after an MI, especially if the papillary muscles are damaged. Within hours, You can have displacement of the papillary muscle due to inferior wall hypokinesis, and a few days later, it can rupture completely. The posteromedial papillary muscle is the usual culprit because it only gets blood from the right coronary artery. Other causes include chordae rupture from MVP, endocarditis, rheumatic disease, or trauma. In acute MR, the left atrium and left ventricle are still normal in size, so the sudden regurgitation causes a massive pressure rise in the left atrium, leading to acute pulmonary edema and sometimes cardiogenic shock. The murmur can be soft or even absent because there's not much pressure gradient between the chambers. These patients are in crisis, hypotensive, with pulmonary crackles, jugular distension, and cool extremities. Diagnosis is made with bedside echo, and the treatment is emergency surgery. Now, compare that to chronic MR. Here, the regurgitant volume develops gradually, so the left ventricle and atrium dilate over time to compensate. Patients stay asymptomatic for years, but eventually develop dyspnea and fatigue as the heart fails. On auscultation, you'll hear that same holosystolic murmur at the apex and often an S3 gallop, which means there's volume overload in a dilated LV. An S3 is a hallmark of significant MR, and if it's absent, the MR probably isn't severe yet. Primary MR is due to valve leaflet disease, like myxomatous degeneration or a cleft cusp. Secondary MR happens because of LV dilation, basically, a stretched-out mitral annulus that can't close properly. Treat the underlying heart failure, and the regurgitation often improves. Next up, mitral valve prolapse, probably the most common murmur you'll actually hear in real life. It's caused by myxomatous degeneration of the mitral valve or chordae, and you get a mid-systolic click, often followed by a holosystolic murmur if there's associated regurgitation. What's cool about MVP is that the murmur changes with position. When the LV volume decreases, like when the patient stands or strains during Valsalva, the click happens earlier and the murmur lasts longer. When the LV volume increases, like during squatting or leg raise, the click happens later or might disappear. This dynamic change is what makes MVP so recognizable. Next, aortic stenosis, another step 2 monster. The typical patient is an older adult with calcific degeneration of a normal trileaflet valve or a younger patient with a congenital bicuspid valve. There's a long asymptomatic phase, but once symptoms start, dyspnea, chest pain, or syncope, the prognosis drops fast. The murmur is a mid to late peaking crescendo-decrescendo systolic murmur best heard at the second right intercostal space, and it radiates to the carotids. You might also hear an S4 from concentric LV hypertrophy and a soft or single S2. Pulses are weak and delayed, the classic pulsus parvis et tardis. You can even get paradoxical splitting of S2 because the stenotic valve delays aortic closure. Management: only valve replacement helps. Medications don't fix the obstruction. There's also supravalvular aortic stenosis, which is a congenital narrowing of the ascending aorta. The murmur sounds similar but is best heard higher, around the first right intercostal space. You might find unequal carotid pulses or a palpable thrill in the suprasternal notch. These patients can develop LV hypertrophy and even myocardial ischemia due to coronary artery narrowing. Now, let's touch on chronic pulmonic regurgitation. It's usually iatrogenic, after correction of pulmonic stenosis, but can also happen with rheumatic disease or endocarditis. It causes a decrescendo, diastolic murmur at the left sternal border that gets louder with inspiration. Over time, it leads to RV dilation and failure. Treatment is serial echocardiography and valve replacement when symptoms, or RV dysfunction, appear. Finally, tricuspid regurgitation. Most of the time it's secondary, meaning the valve itself is normal but stretched open due to right ventricular dilation, often from left-sided heart failure or pulmonary hypertension. The murmur is holosystolic, best heard at the left lower sternal border, and it increases with inspiration. You'll see jugular venous distension with prominent V waves and peripheral edema. On the JVP waveform, the V wave becomes huge because the regurgitant blood is going back into the right atrium during systole. So, to summarize, think of murmurs as windows into the physiology. Holosystolic means regurgitation, diastolic usually means pathology, and changes with maneuvers can tell you which side of the heart is involved. If it gets louder with inspiration, it's right-sided. If it gets softer with squatting or louder with standing, think MVP. And if it's a harsh systolic murmur that radiates to the carotids, that's your aortic stenosis. Alright, that's a wrap for valvular diseases. A lot of details, but they all follow predictable hemodynamics once you understand the physiology. In the next episode, we'll go into heart failure and shock states, where we'll connect all this back to how the heart compensates when valves or contractility fail. Keep sprinting, and remember, mastering the flow is mastering the Step 2 CK.